Thank you, ma'am, and good evening, everyone. And ma'am, thanks for the nice introduction. I suppose I'm the only surgeon available in this auditorium among so many nephrologists. Nev- oh, nevertheless. So we all know there is a long waiting list of the patients who are awaiting renal transplant. And for these patients, without the organ, there is no story, no hope, and there is no transplant. So once the So once the organ is available, the life springs from the death, the sorrow turns to hope, and the terrible loss becomes the gift. However, things may not happen in the way that we always expect. We might have issues while the organ is being retrieved from the cadavers, especially once it happens when there is a circulatory death. We might have a perfusion issues where we can see in this picture the kidney is still red, the organ is not perfused well. So we know this patient are going to have, once the kidney is being transplanted, we are going to have a high RI and we may have a delayed graft function. Other than perfusion issues, we have a long cold ischemia time, especially when the organ is being retrieved from far-flung centers. This is a common scenario in our setup where we have most of our zonal hospitals being approved as a retrieval centers, and we have only 6 approved transplant centers. So our team usually travel from R&R to various zonal hospital to retrieve the organ, and all thanks to the support from Indian Air Force, where they provide us with these small flying objects. Every time we ask for them within a limit of less than an hour. Another issue of increased cold ischemia is because of a surgeon being awaiting a cross match. At our center, it usually takes 6 to 8 hours time. I suppose other centers take 4 to 6 hours before being the cross match is being available. These all things add on to the more and more cold ischemia time, and for this duration we have to preserve the organ. So what are the options available with us during this duration to preserve the organ? One is the conventional option, that we have done the benching, we have perfused the organ, and we usually pack the organ in this plastic bag, and this bag is being kept in a ice box steel container covered with the ice. But the issues with this is, as sir has already said, Dr. Raju, that in one patient the kidney was frozen. So these are the issues once we keep the kidney in a steel container, because usually the fat is frozen, or sometimes, as sir has already brought out in the previous presentation, the organ is being frozen. So what else is available with us? Yes, there is a solution available with us, is the use of life port system. Once we have to transport this organ for a long distance, or we want to preserve the organ for some duration of time before the transplant is being done. Greetings from Army Hospital R&R. I used to work in this hospital a couple of months back, and I am presenting my experience from this hospital. And recently I have been shifted to this. This is the biggest zonal hospital of the armed forces. It's a military hospital, Jalandhar. And recently we have been in a news. Last month we have did the first retrieval at this center, and this has got a huge media coverage, because in Punjab, you know, the organ retrieval program is not doing well. So it was done after 3-4 months, and it was first retrieval being done in any central government hospital in state of Punjab. So nevertheless, back to our topic of discussion, the life port system. How does it work? Other than providing the hypothermia to the kidney, the main function of this life port system is to provide the continuous pulsatile infusion to the organ. So this life port system comes with the consumable component. You see, these are the consumable components which come with this life port system, and this is a main cradle or a life port. If you see this machine, there is this is the ice box. This contains almost 8 to 10 kg of the crushed ice. This box maintain the temperature of this cradle below 4 degree for 24 to 36 hours, and this comes with the additional batteries and a charger. So once the graft is being prepared, we have perfused the graft. We open up this sterile canister. Once we open this canister, you can see there is a cradle along with this mesh. The purpose of this mesh is to keep the organ safe while the organ is being transported. and this is the sterile circulation system or sterile tubing which are being connected to the renal artery along with the sealing cannula. So these are the disposables along with the sterile drapes which come with every pack. So once the benching is done, the most important step is to place a sealing cannula. This is known as sealing cannula. So there are different type of cannulas which are being provided with this LifePort system. If we have a aortic cuff, we have a different cannula. If we don't have an aortic cuff, we have a different size cannula. For different size arteries, we have a different cannula. If we have a double artery, we have a different cannula. So the most important thing that we should know and we should learn is to how to place the sealing cannula on the artery, because if there will be a fluid leak, the perfusion will be inadequate. So once the sealing cannula is being placed on the artery, the tubing system is connected to the main circulation system. Before connecting the circulation system, we should ensure that there should not be any air bubble inside this circulation system, because otherwise it will not work or it will show as a high resistance. Once this is done, it is covered up, it is packed, and each and every parameter is available from outside. You can see the temperature, the perfusion pressure, everything is available from the outside. After this, the sterile drape is removed, it is sealed. Even you can put up the patient data also. Suppose we have 2 kidneys, so we can label these kidneys, we can label this box where this box has to go. Suppose this graft has to go to a different center, we can label it on this box digitally also, and it is easy to carry. It comes with the wheels, we can easy to carry. If you want to take it by air, it can be taken in the flight also. So coming to our experience, so we had a total number of 62 patients, out of which 34 were on the hypothermic perfusion and 28 were on cold static perfusion. In machine perfusion group, we have 2 patients who had a delayed graft function as compared to 5 patients who had a delayed graft function in a cold static perfusion. The parameters recorded were serum creatinine, urine output, and eGFR. After excluding the patient with the other causes of death, we have 31 patients in hypothermic perfusion group and 21 in cold static group, and this is the data being collected. So what was the outcome? In a mean, the cold ischemia time was comparable in both the group. The urine output at 24 hours were better in the machine perfusion group as compared to the cold static group. However, it was not statistically significant. If we see the fall in serum creatinine, it was better at day 7 and at 1 month in a machine perfusion group. However, it was not statistically significant. It equalizes by 3 months and it again falls at the 6 months duration of time. At 6 month duration time, it was not statistically significant. The eGFR was better at day 7 and at 1 month. It almost equalizes by 3 months and again it improves by 6 months. However, in all this group, there was no statistically significant difference was noted in both the groups. But if we omit the patient who had a cold ischemia time of less than 8 hours, so the patients having a cold ischemia or the graft having cold ischemia of more than 8 hours, we had a 24 patient in machine perfusion group and 19 in cold static group. So what were the outcomes? See, the cold ischemia time was more than 10 hours. The urine output at 24 hours was statistically significant in the patient who were put on the machine perfusion group as compared to the cold static group. The serum creatinine at day 7 and 1 month was statistically significant in a machine perfusion group. It almost equalizes but remained better at 6 months. However, at 6 months it was not statistically significant. Same thing happened with eGFR also. The eGFR at day 7 and 1 month was statistically better in machine perfusion group, almost equalizes and remains better at 6 months in a machine perfusion group. So what is the importance of this creatinine at 7 days, 1 month or eGFR at 7 days and 1 month, is it going to have a long-term effect on the graft function? What does study says? Study says yes, if there is a long cold ischemia time, yes, we are going to have a delayed graft function. In machine perfusion group, we had only 2 patients with a delayed graft function as compared to 5 patients in a cold static perfusion group. The serum creatinine level at 1 month is a independent predictor of long-term survival. So a patient on machine perfusion where the cold ischemia was more than 8 hours, they had a statistically better serum creatinine at 7 days and 1 month time, and we are anticipating that these patients, if we are following, will be following in long term, are going to have a better graft survival. Same thing happened with the creatinine clearance. So studies have said if the creatinine clearance is less than 50 ml, the annual graft loss is almost 13% as compared to less than 3% if the creatinine clearance is more than 50 ml. And the urine output at day 1 is again an independent predictor of long-term graft survival. So in machine perfusion group, again the urine output at day 1 was significantly better in a patient who has a cold ischemia of more than 8 hours. Again, you must have been seeing my second slide where I have shown the patient where the kidney was not perfused well. See, we have put up this kidney on the cradle. See what was the initial resistance. Initial resistance on cradle was 2.3. So once this organ was placed on the perfusion for 4 hours, the resistance came down to 0.6. So this graft worked well once the kidney is being perfused on the life port system. And studies also support the same data, and there is a new literature which has come up that even in a living donor, we should first put up the kidney on the life port system, see whether the RI is favorable or not. If it is high, keep the organ on the life port for some duration. Once the RI comes down to less than 1, then only do the transplant. So what are the advantages? Basically, to sum up, it provides the sealed environment, it's a portable system, it records data, we can, it comes with a chargeable battery, it reduces the delayed graft function. Another thing that ma'am was saying, there was a graft loss of almost 30%, ma'am, you said. So you said we can do the biopsy also. So what I can think of is we can put up these kidneys which are being discarded on this machine, do the biopsy, wait. So we can save almost, I think, even not 30%, even 10 to 15% or maybe 20% of graft can be saved. We put these graft on the machine, do biopsy and wait for some time. There is no harm in doing that. So what are the disadvantages? It requires a technical training. We should know how to put up. The main step is to remove the air bubble from the tubing system, and we should know how to put a sealing cannula on the main renal artery. That is a main hurdle in learning the use of this machine. Yes, initial cost of this machine is higher, but ultimately what is important for us is a graft function, that if we are getting a better graft function, yes, cost is not that important. To conclude, what we have come up with our study is if the cold ischemia time is more than 8 hours, yes, we are getting a statistically better creatinine at 7 days and 1 month and better EGFR at up to 1 month of time. And long-term data from our study is still awaited. Next time possibly we'll come up with data of 1 year and 1.5 year survival of the graft of our patients. Thank you.